मैं वहाँ पे बैनर चेंज कर दूंगा, विजुअल नहीं जाएगा, इतनी देर में हम माइक चेंज कर लेंगे। जब चेंज हो जाएगा वो स्टार्ट करे, वहां से बढ़ जाएगा कि ऑडियंस को हर चीज क्लियर मिलेगी। वो नहीं आएगा कि और माइक चेंज, ऑडियंस को कुछ भी नहीं ऐसा नजर, जो यहाँ पे मौजूद है सिर्फ उनको नजर आ रहा होगा, वहां वालों
ठीक है। अच्छा, इसकी रिकॉर्डिंग होगी?
को यूट्यूब ऑडियो वहां से डाउनलोड कर लें, नहीं होगी तो फिर हम बता दीजिएगा, होगी तो ऑलरेडी मैं तीन जगह पे रिकॉर्डिंग कैमरे में भी होगी है। नहीं, हाँ, उसके अंदर वो पड़ा हुआ है मेरे मोबाइल में, जैसे सब ने मुझे भेजा हुआ है। अब ये नहीं पता कि अभी वाला है या रात वाला है, मुझे अभी सुबह देखा मैंने सुबह। सर वो इधर आके करेंगे बात, इधर आके खड़े होकर उन्होंने करना है, उधर नहीं खड़े होंगे, इधर होके करना है उन्होंने। हाँ बैटरी लो, मैं देखे हैं वो चार्जर देखे हैं, अभी चार्जिंग तो लाओ। हेलो, हेलो सर, इधर देखो सर, इधर देखो है, ऐसे नहीं करेंगे, ठीक हो गया, ऐसे तो नहीं, इधर भी आते तो इधर भी हो, ऐसी है। हेलो ऐसा है जल्दी।
अच्छा, केबल साइड पे करा दे, बुरी लग रही है इन लोगों को, परली साइड से कर
जी जी,
दो केबल।
अच्छा ठीक है सर, इधर देखो। ओहो नहीं, एंड्रॉइड केबल वही नहीं, रैम भी उसी का ही होगा, रख दो बैग।
जय शायद है लगे
कल सुनो, इधर आवाज आ रही है,
ले अभी नहीं
लाइव करता उन्होंने, यस सब उन्होंने करता है सब लाइव, लाइव चल रही है। अच्छा वो लाइव का लिंक मेरे पास है, जिन जिन को देना सबको दे दो, करना वो मैं कर दूंगा, वो मैं कर दूंगा, मैं कर दूंगा। अच्छा अच्छा बेटा बात सुनो, इस वक्त हम लाइव है, इस वक्त लाइव है, विजुअल कोई भी नहीं चाहे, ठीक है, जिस वक्त लाइव करने से पहले आप जिसको मुझे इशारा करोगे, मैं वहां से उसको से लाइव बैठे बातें शातें करनी चाहिए। मैम जिसको बताएंगे, जिसको आपने फ्लावर शुरू करनी है मुझे बताइएगा, ताकि मैं वहां से एक्टिव करा।
डेकेड्स डेकेड पर भाई आपकी बहुत ये ऐसा पोडियम है जहाँ पर फर्स्ट टाइम हमने ही प्रेजेंट किया है जब ये फोन कर दो, फोन कर दो। अच्छा मैडम, मैंने आपसे इसमें आपके पास नहीं होगी? नहीं तो यूएसबी पे यूएसबी जल्दी नहीं है इससे, दूसरी लगानी पड़ेगी मैम, ईमेल होगा। अगर आपके पास मेरे पास वो नहीं है,
वो नहीं है ना,
कनेक्शन है, अगर मैं ईमेल
ईमेल कर लेना।
कैसे करेंगे? अगर आप इसके पास मेरे पास तो वही है।
वो हॉटस्पॉट करने से, हाँ मतलब कैसे मैं ईमेल काफी हेवी फाइल है, जाए नहीं जाएगी फिर।
स्टडी पड़ी हुई है,
वीडियो नहीं डाली
वो लाइव में डिस्टर्ब करके एकदम टी शर्ट बात है बेहतर हुआ।
पता है मैं भेज दिया वही उसको, शहबाज को मैंने यही भेजा था। अब बस 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 तो छोड़ दो, मैं दिखा करूँ लग रहा है ऐप। ओ ये है ना मेरे
जस्ट आपने इधर से लॉग आउट करना है।
बस ठीक है ना,
इसको साथ में करूंगे।
बस इसको मैंने डायरेक्टली करने जा रहा है, डायरेक्ट वो भी जा रहा है, आपका काम भी चल रहा था, हो रहा है। It takes some time. We're
जी सलामकुम, क्या हाल चाल है आपका? बिल्कुल ठीक। जी सलामकुम मैडम, डिपार्टमेंट वेलकम। मैडम आपका तो इंतजार आपके लिए। हम दोनों एस्पेक्ट कवर
मेरे साथ में आप लोगों के लिए फायदा होता है, वो बहुत अच्छा जैसे वो जब बैकग्राउंड बहुत अच्छा करती
ना हम या तो अगर वो आ सकेंगे या फिर हम कोई वेबिनार
डाउट भी कर रही हूँ,
मतलब डेट्स
मैं जा सकती हूँ,
हम तो always welcome. Yeah, both the aspects should be covered.
आर्या ये बात
We'll give some introduction and then first a little introduction.
बैठ जाओ फिर मैं
Yes, ma'am.
मत धीरे बात बहुत ही अच्छा लग रहा है
हो गया?
शुरू करना है?
नीचे आ गए।
शुरू करने लगे चलो ये लगा
ये हो गया ट्रांसफर?
नहीं
हो गया?
फिर लगा लो
स्टार्ट कर प्रोफेसर साहब।
लैपटॉप थोड़ा सा मूव कर सकते हैं क्योंकि फेस छुप रहा है आपका।
मैं इधर आ जाती हूँ। कर दें कर दें। ठीक है। जुनैरा सर से पूछो स्टार्ट कर लें। हाँ हो गया।
बस मैम के तो presentation आ गई।
डाउनलोड हो रहा है, थोड़ा सा वेट करना। हो गया डाउनलोड? कर ले सर ठीक।
पूछ लेना था क्या क्या कौन सी चार में बोलना है।
सर वो मैंने थोड़ा बहुत ले लिया है। Bismillahirrahmanirrahim. Good morning, distinguished guests and esteemed colleagues. I am Dr. Wajiha Nusrat, Senior Registrar, Dermatology Unit 1, Mayo Hospital, Lahore, and I welcome you all. I am feeling very honored to be the part of this pre-paired conference at Mayo Hospital, Lahore on the topic of biologics in psoriasis. I am truly grateful to each one of you for dedicating your time to this academic activity. Allow me to begin by extending a warm welcome to our chief guest for today. Our first chief guest for today is Professor Dr. Tariq Rashid. Sir is a member of CPSP Derma faculty for 10 years, member of MD Dermatology Advisory Committee for UHS. Sir is an examiner of FCPS, MCPS, and MD. He has many publications in national and international journals. Sir has a special interest in teaching and training in bedside clinical skills, and he has conducted many educational workshops and preparatory courses. Thank you, sir, for being here. Our second chief guest for today is Professor Dr. Farhana Muzaffar. She has earned her expertise in dermatology and has an experience of over 30 years. She has retired as Professor of Dermatology and Head of Department of Dermatology at Children's Hospital, Lahore. Thank you, Madam, for being the part of this workshop. Our two more chief guests, Professor Shehbaz and Professor Tahir Jamil, will be joining us soon. Now, allow me to introduce you to our speaker for today's pre-PADCON workshop. She's none other than Dr. Huma Rehbar. She graduated from Rawalpindi Medical College in 1989. She did her FCPS in 1996, served as an assistant professor, and then moved to Saudi Arabia, where she did her MRCP. She served in Singapore, and now she's working as an assistant professor, Northern Ontario School of Medicine. Her expertise and insights are pivotal to the discourse we aim to foster today, and we are honored to have you with us, Madam. Thank you, Madam, for joining us. Madam, I'll invite you. Ma'am, I'll invite you after the welcome address by Professor. Ladies and gentlemen, join me in giving the most cordial of welcome to rest of our worthy guests and seniors like Professor Faria. Thank you, Madam, for joining us. Once again, welcome you all and thank you for being the part of this important discussion on biologics. Looking forward to a productive and insightful day ahead. Before we commence, let us begin with the name of Allah, the most gracious and the most merciful. I would like to invite Hafiz Asif Tabros for the recitation of Holy Quran.
Thank you.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم إن الذين قالوا ربنا الله ثم استقاموا تتنزل عليهم الملائكة ألا تخافوا ولا تحزنوا وأبشروا بالجنة التي كنتم توعدون نحن أولياؤكم في الحياة الدنيا وفي الآخرة ولكم فيها ما تشتهي أنفسكم ولكم فيها ما تدعون نزلا من غفور رحيم صدق الله العظيم.
Now, I will request everyone to please rise for national anthem to sing with heartfelt zeal and enthusiasm. Please rise. Thank you, everyone. So before we begin, let me introduce you to our worthy professor, Ijaz Hussain. Sir is a chairman, and welcome, Dr. Nadia, for joining us. Ladies and gentlemen, I also wish to acknowledge with gratitude to Professor Dr. Nadia Ali Asfar, who managed to attend this pre-PADCon workshop in spite of her busy schedule for the upcoming pre-PADCon. Madam, your presence elevates and broadens the scope of our discussion. So before we begin, let me introduce you to our worthy professor, Ijaz Hussain. He is chairman and head of dermatology department at King Edward Medical University, Lahore, with a career marked by exemplary leadership. Sir has previously served as Pro Vice Chancellor, King Edward Medical University, President of Pakistan Association of Dermatologists, and President South Asian Regional Association of Dermatologists. Sir has remained the editor for JPAD for almost 15 years. I invite Professor Ijaz Hussain on stage for his welcome address.
Uh, Ladies and gentlemen, Sir Tariq Rashid Saab, Dr. Farhana. Dr. Farhana served as the first professor of pediatric dermatology. She is not only dermatologist, but pediatric dermatologist. Dr. Nadia Ali Asfar and highly respectable Professor Dr. Humarabar. Dr. Humarabar, Sir Tariq साहब, Dr. फरहाना, हमको ये ऑनर है कि हमने मिलके इकट्ठे ट्रेनिंग ली, तो हम उसे वो ग्रुप ऑफ 9 कहते थे. तो अभी इत्तेफाक ऐसा है, अभी ताहिर जमील साहब भी आ रहे हैं, तो वो आ जाएंगे. तो दूसरे जो मेंबर्स थे उसमें डॉक्टर मोहम्मद खालिद साहब, डॉक्टर गुलमान मुश्तबा साहब, प्रोफेसर शाहिद जावेद अख्तर साहब. Today we have gathered here for the pre-PADCon workshop, role of biologics in psoriasis, and our honorable speaker is Dr. Humarabar. She has traveled from Canada. Especially, she will discuss how can we use biologics in psoriasis. It would be first there would be a lecture and then would be followed by interactive session. We can learn anything, we can exchange our experience with her, because almost all type of biologics are available in Canada, but due to certain limitations, we have access to few drugs, so that we can learn from her which biologics is suitable in which type of psoriasis and other things, practical difficulties which we face here. So thank you very much, all of you, for sharing, for sparing time to attend this workshop. Thank you.
Thank you.
Thank you, sir. Thank you, sir. Unfortunately, our second speaker for today's workshop could not attend due to some unavoidable personal commitments, and she's back to Canada. But don't worry, as long as we have the whole galaxy of dermatologists around, we'll do great. So let's start and begin by inviting Dr. Huma Rehbar on stage for her insights on biologics in psoriasis.
Bismillahirrahmanirrahim. Assalamu alaikum to all my colleagues and my respected, well, I will also say respected colleagues and the young juniors, seniors, and everybody, and Dr. Huma. Well, the name that you must have been seeing, there are lots of Humas around, and there's a little bit of confusion. But before I begin, I just wanted to let you guys know that you cannot imagine how it feels standing in here. I think you just cannot, because when this auditorium was first created, we were the first ones sitting at the back. And Allah subhanahu wa ta'ala, Professor Harun ko जन्नत में बेहतरीन मकाम अदा करे कि जिसकी वजह से I can commit, मतलब मैं पूरी बोल भी कह सकती हूँ, what I am today, what I'm doing today is because of Professor Fahid Faigal. So मुझे ये लगता है कि अभी से ये दरवाजा खुलेगा, and then he will come back and say, Huma, come on, your slides are not up to the mark. We cannot be seen at the 6 week level, and we need to have like two different, like you have because at that time we're talking about 1991, 92, 93, 94, 94 was my last year in here. But आपके पास एक दूसरी स्लाइड होनी चाहिए, एक आपके पास USB होनी चाहिए, या whatever, two forms of, because there was somebody who missed and all that. So what we are today, even a single word of it all goes to Professor Tahir Said Harun. So a movement of silence के साथ साथ, हम silent तो रहना बहुत मुश्किल काम होता है, क्योंकि आजकल ये कहते हैं कि अगर आप silent हैं तो आप किसी के साथ नहीं हैं, तो आप silent ना रहें और एक सूरह फातिहा पढ़ें प्रोफेसर हारून के लिए, फिर हम शुरू करें. So this fond memories when I have my path and you guys have your paths with me. आपके पास भी professors हैं, मेरे पास वो professor थे, और मेरे पास इतने अच्छे colleagues हैं यहाँ पर. So let's start off with the emergent biological treatment for psoriasis, and as Dr. Jaz was telling you, I picked this up particularly because I know I was there at your stage at this time, that what we were craving for, all the kind of the knowledge, from here, from there, from everywhere, that, okay, the psoriasis is something which is a common disease. And by the way, when I was a resident, the psoriasis was supposed to be a papillospermous disease. Now it's an immunological disease. It's like we have leaped like centuries and centuries in advancement, and it's still going on, actually. There's a new biologic popping out every 2 to 3 weeks. And then especially the residents have to remember, okay, IL-20, IL-23, IL-17 and what that, but it's more than that. Because once you know the basics, then you can do the best for yourself and serving your patients. And that's the goal that we all achieve. So currently I'm in, as she said, that I'm in Canada. Yes, I'm practicing for the last 3 years in Canada. Before that was at a decade in Singapore. And in Singapore, I was the program director for the dermatology, and I revamped the programs to the ACGME where I did over there. And before that was Saudi Arabia and Bahrain. And I also had my specialist certificate and MRCP from the UK. But I am a clinician educator, and I'm proud to be so, because this has been instilled in me by Professor Harun, right? So I was the one who never stopped talking in front of him. So my professor used to tell him, please, if you go and put a bolina on the sun, but this is not happening with Dr. Humar Eber. But anyway, so that's how we go. I'm an educator. So then I went to Netherlands for having my, teaching polished up there. So then I knew, what it taught me. It hasn't taught me anything, but it has taught me something, that what I'm teaching is why I'm teaching. So this is very important to put in the shoes of the residents and go there and talk about it. All right, so let's talk about it. I have a lot of stuff to talk about because I've just added a few things when I talked to Vijiha last night. Is because our colleague is not in here, but I'm not a researcher, so I won't be able to give you the insights of how the trials are being done. But I'm sure that there are expert people over here who can follow you up for the trials. She has a wealth of experience, and I'm sure that she will come up someday and talk to you. So for now, we're talking and concentrating on the newer biologics. But then I was told, like, okay, let's have a little bit of the background brush so that we know what are we talking about, because my talk was geared towards the newer biologics, which is IL-23 and IL-17. But we definitely will do more to it. So what you see in here, I just put this slide as thinking paradigm for all of you, is that what you see is, some people will see it's a sunset, and some people will see as a sunrise. By the way, this is a shot that I've taken from my own home. So this is, for me, is a sunrise. And for that sake, every day is a sunrise. So that's how you have to take the challenge in life, is that, okay, it's going to be difficult, but you are there to take the challenge and rise up. And definitely there is nothing behind that which can stop you. I have a few disclosures. Yes, I don't think so that you need to read this, but I can give you my disclosures if there is anything. All right, so today the scope of the share was actually because of the optimization of the biologics, the newer therapy, and the consideration of their safety data. But I've added some more, and it can be some more and some more. It's non-ending. So I will definitely bring you guys up, and you have to answer a few questions. Otherwise, it's going to be just me speaking, and that's not happening with me. Okay, great. So. Well, it's the light that's there, and the one light makes so many lights, and that's not the burnout. Initially, it was used for one of my colleagues over there for a burnout, but I see it differently. So it all depends upon how you look at things, It all depends upon it's half full or half empty. So try to see it half full rather than empty. All right, so let's start off with the case. So this is one of my patients that he is 49, he's male, gender matters. Then he has psoriasis and psoriatic arthritis, and he was actually referred to me by a rheumatologist. So by the way, that brings out the collegiality in the field that we work in over there. It's a little bit different environment. I've been here, I know how it works in here, but over there, you really have to be really particular about what you're doing, why you're doing, and I'm sure we do over here as well, but referral wise, So I got this from one of my colleagues as a rheumatologist, and the story is that he said it's psoriatic arthritis, and he was seen by another doctor, another dermatologist before. He failed a lot of treatments with his topicals, the phototherapies, and then you can see the methotrexate, and then there's sulfasalazine and lefuronamide is basically for psoriatic arthritis by him. So, but he didn't meet up to the mark, and he was better in psoriatic arthritis, but his skin was getting worse, and that was I've been called in, right? So to enter. So looking at all that, I'm comfortable in prescribing the biologics. So of course, with all these failures, and we do have our restrictions of whom can receive the biologics, because you have to fail, and it's a step ladder pattern kind of a stuff. And topical fails, and the UV fails, and then the one or two of the immunosuppressants fails, and then you can do for the biologics. So I opted for the for IL-23, and this risankizumab, this is Skyrizi that we call it in here, there at our. I guess that you guys are using the TNF alphas, right? And also and 17, which one of that? Cosentyx, right? So, secukinumab. Sorry for the, because I was actually the PI for the Cosentyx, and I can tell you some things about it. And yeah, so we can concentrate on that, what you're doing Cosentyx and what to look for and what to not. So this is IL-23, which I started him on. And this quality of life was drastically, it was bad. It was 22, and this is all like the joint scores with 3 and 4. And his CPR was not so bad, actually. 6 is not a bad, but the X-ray does show the erosive disease, so it's definitely have psoriatic arthritis. But and he has the comorbidities as well. He was obese. Okay, it's a typical psoriasis case. So, you come in here and then you ask, oh, that's a trio of diabetes, blood pressure, cholesterol. So down in there, right? So he had those things. So we were co-managing, of course. So you can concentrate on this and what I did. This is like a question what you're supposed to be doing for the younger generation, whoever. That's a good exercise of my mind, is how I classify them into, okay, I don't miss anything in them. So it was co-managed with our room colleague, and his PASI was in the beginning wasn't so bad, 19.4, BSA of 31%, and a global score of 3. So what was our consideration was to have a good, rheumatological as well as the skin coverage. Okay, that's very commonly seen when you're sitting in a psoriatic clinic or any outpatient clinic. So, and then we were looking forward for that, right? Then what happens is that, okay, so we have to balance the safety and all that, what we are talking about. He did have nail involvement as well, right? So this is also one of the things which that it's difficult to treat, and the topicals, I don't think so. It makes much of a hell of a difference. So we co-managed, and what we did is, this is what the patient is, right? So this is a baseline, and if you can see, you can appreciate it's quite thick scales all in here. And if you go for the NAPSI, it's 34 of a NAPSI, and so the nails are involved, and hand and feet. If you, this is for somebody who doesn't know the NAPSI. This is the reference, and you have like every nail is divided into 4 quadrants, and then you have 10 nails in the hands, 10 nails in the feet. So 160 spots that you're examining for what? A nail matrix, and of course the nail bed changes, right? And then how you got it. So he had 34 of that, but more importantly, that he was very distressed with it, because he didn't like the look of it. His quality of life was down to the drain, and then we got into something about it. But look at that. So 6 months post IL-23, which is risankizumab, but I call it style easy, and it's easy dosing. Do we have ustekinumab in here? Right. So, and it is available for the dermatology as well. So this is a bigger sister for the ustekinumab, and it's specifically also in the dosing, because it's very convenient dosing. We're usually loading dose, and then every 3 months that you do it. So this 6 means only 4 doses of that jab, the injection needles, and then he was rocking good. And he was saying that he loved it, because that has changed his life. That has changed his perspective to what he should be doing. So, well, a question about the PASI 0, BSA, and you know what? I mean, they're good. They're good for the trials, but when you're sitting in a clinic, it's really difficult, and it's also have a bias of like what I see as a 0, what you see as a 0. So it's still a little bit of a scaling. Well, I don't know whether it's 0 or 1, but he was very happy, and that's what my end goal was, right? So, and then if you talk about the NAPSI, is from the 34 to 7 is reduced down to that for just like 4 jabs, and you make a difference for so many years of the suffering for that patient. But it's not only suffering, at the end of the table, that it's not all about suffering. It's all about, it's a full-fledged immunological disease which affects your internal organs. So when you tell them, they just say, hey, really, is it related to the diabetes? Yes, it's related to the diabetes. It is related to the cholesterol. It's related to and a lot of my patients, that these are the routine questions. And then I can share you what I do that. But what would you do next if he is coming in a 6 months time, and he's having a PASI drop to almost 1 or 2 0? Anybody can tell me that you would like to continue on with it? Anybody, or any residents can forward. Come on, you guys treat them, don't you? For the maintenance. So of course we need to continue. That means that you will be, what my question is that, would you be continuing the IL-23? Yes or no? Yes, but it will depend, whether he can afford it. So I'm not giving him for only 6 months to get a clearance out of it, but I'm giving him a different lifestyle and he's looking forward to it, right? So that's what your patient does. If they come to you and they're looking forward to it, yes, of course, we're looking forward for a continuation, but it's a very common questions that you're facing is how long, doctor? And I don't have an answer. So you have to tell your patients that it's a lifelong disease. You can go into remissions. You can try after some time, but that sometime is not delineated. There's no guidelines to those time, but that governs a lot of steps to that. Maybe money, maybe, maybe sometimes they have in back home that we have insurances if there's somebody is covering for that, because it's really about that. Is it? And is it available or not available? What's the availability in that sense? And then also the safety concerns. Is it really safe to give him for the next 5 years, let's say, for the 10 years? These are the questions that should be coming into your mind when you're continuing with that, right? So what are the optimizing biologics in psoriasis? And we'll be looking at the goals, what you should be doing, and we're looking at the modifications of what treatment that you should be taking. And specifically, I was geared towards the biologics, but I have added some slides last night with the jet lag. So if there is any lag in here, please excuse me for that, right? It's a long flight from Toronto to here, right? Anyway, so and then what we can do practically about it, right? So coming back to the basic, there is definitely an unmet need to the psoriasis. I'm sure that your Mayo Hospital outpatient has not changed. Like we had like till 2 o'clock, 1 patient, 2 patient, 20, 100, 200 patients. And really when I applied for the MRCP over there, and the specialty certificate said, how can you see 200 patients in one day? I said, you come to the dermatology clinic and you will know how you see. So that's what all we do. So there's unmet needs. You need something which works and which will make a difference. And I remember we had tar rooms there, tar baths were there. That was the time. I'm so Asian, right? So I remember that. They're still doing it in the UK, actually, by the way, right? So, but Americans and the British are little bit having a little dispute in that, but whatever. Well, they are more towards it is overwhelmed with the pharmaceuticals, I must say, in the North America. And that's why you're seeing a new biologics every 3 to 4 months coming and jumping around. But anyway, so this is the opportunity we definitely need those. And these are the old trial tested, right? We know that. We know the methotrexate, we know cyclosporins, we know acitretin, and we also know, and we call them small molecules, okay? And we also know that this is like a review of everybody that you're doing. So methotrexate, of course, time-tested dermatology, time-tested rheumatology. And definitely 2 things in coming to the methotrexate, I have to wash the liver. I have to see the kidneys clearing it well. And third thing, that I have to see that there is no bone marrow suppressions. These are the major things, right? So you need to, and then that's the safety. And the cyclosporin is more gearing towards the kidney, right? If the blood pressure is there, then I would not think about it, forget about it. And the acitretin, of course, the joints and the lipids and the cholesterol and the heart issues. So it's very common. In North America, the CHF or the cardiac diseases are very common. So we have to be really careful about that. But of course, these are very good MMHs. I'm not saying that you discard them all. No, there's no question to it. But if you have an arthritis, then we can skip the acitretin because that's not working. But cyclosporin for a quick response in a year, and methotrexate for maybe a longer period of time. So that's what you do. I'm sure that you're doing it. Is there anybody who wants to add on anything that you're giving in here? Of course, there's a more, a lot of I can say the previous treatments that's there. But do you have any comments? Any residents commenting on that? You guys have patients on methotrexate? Is that correct, right? And then you do have like on cyclosporins and you see all those, right? So those are the highlights that I'd say. Of course, there are a lot more to the, safety profile. And then there are other small molecules which are also coming like, PDE4 inhibitors and then the TYK2 inhibitors. They are just coming up in there, but they are only indicated for those kind of psoriasis which are not actually good for the topical. So they're not very strong, kind of a psoriatic agent. So I wouldn't recommend them very highly, but they have an advantage. That's why I put them here. And the advantage is that they're quite clean of the side effects, right? So you don't have to worry about a lot of stuff. But also that they don't clean up the psoriasis as well as that. So you really have to balance, what are you looking at? But the downside of them is that they're as expensive as biologics. So if I have to give something, well, I would choose a biologic to give a difference as my patient, 6 months and boom, my cost is zero. I would go for that. I love it. And of course you should as well. So the small molecules, they're new coming ups and all this. We're not going to talk about it, but just to let you know this, the residents are here, these are the ones. So you really have to balance. Otherwise you will definitely fall back, right? And you have to balance not only on one thing that what you want to do, it's to think what patient wants to have an outcome. And there should be a central point where you two agree to it. I know that this is, I hope it's not mine. Yeah, it's not good. Okay, so it's so I know that there is a difference in how we treat patients in Pakistan. I was here, I trained here, right? And we do it up there, is that we definitely look up and we ask about how the patient is comfortable about it and what they want. That's very important, actually. And that's very important even everywhere. I was once told by one of my colleagues, hey, that's what you do in here? Well, you spend a lot of time with the patients. I think I have to, because I'm caring for my patients. This is something which I learned when I went out of the Pakistan, right? But I'm sure that you guys are much better than what we were before. So what are the indications of the biologics there? It depends. So we talk about, it depends whether the patient can afford, whether it's available, what the side effects, what is the baseline, comorbidities that's there. And then generally it's moderately psoriasis and above. But mind you, if the patient is having even a psoriatic plaque on the face, and for example, he's a Hollywood actor, he would like to be gone. He has a hell of a lot of money, right? So he should be treating with a biologic. He has all the reasons to do that, not in Canada, but in States, because in Canada, we have a rule of, we have to step up the ladder. It's still a British colony, so we'll go there. But in States, I'm telling you, in States, it's like you can jump to the biologics because the insurance works there. So people who are insured, they can go, a Hollywood actor can go to grab a biologic there, okay? Or depending upon that you're comfortable or not comfortable. So TNF, the TNF is, there are alpha is missing in here, but inhibitors are there in the market long term. And then we think in North America that the days are almost over, because I think we have seen enough of the side effects. And that makes me nervous also, except for the HS, of course. For the HS, hidradenitis suppurativa, I still give adalimumab there and makes a big difference to the patient's life. But in psoriasis, I will think twice to start with the TNFs, and we know the reason. So the newer one, IL-17s and 23s are in the market, and we'll talk about it, right? So the question for you again, wake-up time. All right, so what are your primary treatment targets? We talk about targets, but what are those, what you're looking forward to? Is it the body surface area? Is it the PASI or whatever that's written there? So, for example, you tell me, when you treat psoriasis, what's your target for the patient? Primary target. Yes, you can ask, you can tell, it's an interactive forum. Dr. Ijaz was telling me we have an interactive forum later. We can have it now because for you, it's not for me, right? So. I need only one thing from one ABCD EG. What would you looking forward to? Okay, you can take it. That's no problem. But the answer will be here, Dr. Ijaz. So it's leaked out, unfortunately. Yeah. None of them? You don't have any of these that what is your primary target? When your psoriasis patient is sitting in front of you, hey guys, come on, what do you do? Yeah. She will tell me. Perfect. I mean, that's perfect in the books. But what do you mean by PASI 75? Are you really calculating in the clinic? Tell me the truth. No. But see, the research head is here. So PASI is in the research. So we don't, right? But we do want them to be less. Anybody else have any ideas? Please come on. Great. Body surface area. So you're looking forward when the patient will come back. If it is, for example, trunk back, you only want to have like a lesser of that, right? And you will document that, of course. And that's what we do. And Walaikum salam, walaikum salam. Right, so that's one of the, actually, you know what, honestly speaking, we can have any of these as our targets. So because they can just be there, you know, there is no guideline to say, hey, you should be, when you're talking and your primary goals should be there, because working in Pakistan will be something different than working in a North America, or for that sake, for UK, for a Saudi Arabia, where there's nothing available down in there, or you know, so you're a foreigner there, then you will be difficult to have anything in Saudi Arabia. But when you're a Saudi, you will have everything. But anyway, so this is what we talk about. So there is also a term and a new concept which is coming up, and I want to deliver, is treat to target. So you have your target and you go treat to target, right? And we say that it can be any of those. So it doesn't have to be PASI 0. If the patient is coming, as you said, PASI 75, well, I don't go with the numbers, but it's okay. If you PASI 75 and he's good and he's rocking about and he's jumping, I'm good with it. There's no problem with it, right? So, so that's what the treat to target concept is. And that's emerging, and you will find in a lot of things that coming up in here. And what do you mean by that is the appropriate treatment selection, and then the treatment targets. Now, talking about the targets will be anything that you see over here. It's not one of those things, but any of those things that will work for you and your patient. That's extremely important. And then you have to monitor the response, right? So response in whatever months that you want to. And depending upon whatever treatment, and we talk about the treatment, the conventional treatments and the biologics, whatever you pick up, then you need to go for that, right? But please tell me if you have a limited time, just let me know. I can. So the maintenance and the treatment response. So then we go for the maintenance, and there will be a time when the patient will say, hey, I want to have a gap, right? I want to stay off. They will go off. They will have psoriasis, they'll come back, and you'll decide whether you're retreating or switching to something else. So that's how it goes. But the concept is target, treat to target. Whatever targets that you've made in the beginning of your patients, then you should be doing that, right? So that's an essentially important thing. And that's what the treatment to targets, the targets in different timelines, you know. They had like, oh, whether that's what you were trying to see, we are talking about. Sometimes it's the BSA, sometimes it's the PASI, sometimes whatever. And this is the PASI response 90% clearance, 100% clearance. So we are now very, what do you say, we are very target oriented. We want it all gone, you know. Before that, we was PASI 75 only. 75, we are okay. But now the studies, if you say they're high achievers, they want to go there and they want to have that. So this is very important, because your patients and the HCPs, healthcare professionals, they prioritize the treatment goal differently than the patients do. They see differently their disease. You see differently. You are 110 things going in your mind when you're putting the patient on a biologic, right? Or for that sake, even methotrexate. Is it liver disease? Kidneys okay? What I'm going to give? I'm starting low. I'm going to call him back for the blood testings and all that, right? So it's different, because their desire for the complete clearance is higher. See, first thing, your desire is low. You're only expecting them 11% to be clear, but they wanted 50% to be, it's gone. So you need to meet their expectations, and you need to have a talk with them. What is your treatment goals? So target to treat, right? So that's extremely important. It's very important. The clear skin is very important to the patient, mind you. And there are studies to that, but it may not be very important to you. But of course, we do want it. We do want a good patient. We do want a patient which is definitely happy. But what we are asking is a suboptimal psoriasis control from the patient's perspective, not from our perspective. So that's important. So do you really discuss the treatment targets with the patients when you start off? Or I know that you see 200 patients in a Mayo Hospital outpatient clinic, you do not have a time to do that, right? But I'm sure in the private practice, you guys, you know, you need to do that. And it should not be limited. That's what I'm saying. I would request. I have been here. I know that you see 200, the residents, 200 patients there. Make time, even 2 minutes, to talk to the patients of what they're expecting. You will be surprised to see how satisfied they are, and whatever that you'll give, that'll work better for you. So this is extremely important, right? Do anybody has any comment on that? Even the honorable guests can also comment, so we can make a make a good interactive session. Dr. Taher? और दूसरे रो से नहीं होगा अभी से पीछे जाके बैठ गए डॉक्टर एजाज अभी तो आई एम टारगेटिंग द सेकंड रो सॉरी okay when and how do you discuss treatment targets with the patients when do you discuss after giving the treatment and then coming three courses and they're coming back and say hey I'm not happy no it should be in the beginning but it should change every time they come that's very important right and then because I tell you one thing, there was a study, I forgot, I haven't put it there, is that when you talk to the patient in a clinic or in something, when they leave it, they only take 10% of what you said. But it was something in the eczema, the children and all that. So you always give a brochure. So give them brochures, give them read-ups. If they cannot read, then tell their sons or daughters about that, right? Whoever is making. Sorry? Oh, so you can have, of course. Perfect. Then you're using two of the special senses, talk, see, and listen, actually 3. So that makes more 10% into 3 times 30% retention. It's still 30%, not 100%, right? But if you give them to read, they will read up. And of course, now I think nowadays, well, I don't know about, I'm sure in Lahore it's there, but not in the remote areas that you will have like internet connections and all that, but you can give them things to read on or the links to read. So make something which is workable for your patients, but this is important that you have to do the targets and talk about the targets, consciously and every visit that they come to. Most of the visits, I must say, well, not every visit, yeah. So they're best to aim, and then whatever that you do, make that one. So we will put our eggs in, not in one basket, and we move on so that we talk more, right? So far, so good. Everybody's awake. Anybody sleeping at the back? I don't know. Somebody are. It's okay, no problem. Sorry? All right, I'll answer you later. So IELTS 17s and IELTS 17Fs, and then this is something which is there, and this is good for exams. You should listen, you should learn, you absorb it, and then you forget it, and then that's it. That's all I can say, because I'm not a clinician researcher, I'm a clinician educator. So I know it should work for my patient at the back end, right? So that's very important. Although, yeah, so I was sharing with you that I was a PI for Casentex, which is secukinumab in Singapore. And it's lovely to start with, good response, but it's not sustainable. So that's what we had, right? So, but anyway, so this is about 17, but I just want to have a word with this, that IL-23 is here and 17s are here, right? So I don't know, what do you think? This should be better or this should be better if you block it? 23, so you nip the evil at the bud, right? That's what they say, right? So, okay, very, very Pakistani approach, and I'm proud to be Pakistani, right? So, okay, fair enough. That's great. Yeah, I mean, that makes sense. But we'll have to see whether we have other things to see whether it's safe to give or which one is better to give, because they're equally expensive. That's also important, right? All right, so mode of action, we know that. So I just want to have a look at this, is because when we talk about those, then you will know what you're talking about, the background. You see the brodalumab is broad, covers everything. So it's not like a specific targets, right? So that is why its action will be broad, so it will be a little weaker, So always think of why these things are happening and dig down to that, and that will help you to remember long-term, right? And then is the BIMI, and BIMI is also a lot, but not like this, right? So it's blocking a lot of receptors, but not like this. Oh, hey, boom, everything is blocked. But and the secukinumab, you can see only poor secukinumab, only 2 of them were crossing there. So it's blocking less receptors. Well, it's working quickly, but it's fading away as well. So that's what it is. And this one is quite broad. So we'll have a lot of cytokines are blocked. So let's talk. I mean, like for example, TNF alpha. Why TNF alpha is so much of a concern now is that because every other inflammatory response is TNF. So it blocks everything for that TNF, right? So that's why a lot of things coming up, lupus, MS, and you name it, and it's there. So that's the concept. That's the concept there. So that's one of the IL-17, right? So those are the ones. And then, so we'll talk about IL-17 first and we move on. but we'll have a little bit of the comparison. We do not have a lot of head-to-head data for that, but yeah, let's talk about this one. So this is these ones are the better ones, 23. And if you see, if it's on the top, then they're better, right? So they're definitely better, followed by the 23s are better than 17s, and then the rest down in there. And you can see the good old etanercept. We used to do that, IV infusions and then all that stuff, whatever. And infliximab, of course, time tested, but yeah, it's a time to move on, probably. And ustekinumab is also there, but it's like the middle of the list. See, that's down there, right? All right, so by the way, you know, I'll put a lot of those stuff, but these stuff, but you know, it's not to confuse you. So we just don't concentrate on there, just get the gist of it. So then you can read later on, whatever that's it, right? So yeah, so it's faster response. All of them, they're faster than IL-23, but amongst them also, some are much faster than the other, and the response are a little bit different, right? So if you see, this is a head-to-head with the ICSI, with the guselkumab, right? So 23 versus 17. So you can see that they're faster, but sustainability will come later, right? Look at that, right? So risankizumab and secukinumab, so the one that I gave to my patient, and then so it's faster. The green one is faster, if you can see, right? This is Cosentyx, but it drops down. Sorry, it drops down after some time, right? But the other one, which is 23, is maybe a slower, but good long term. So that's also important that you need to consider these things in mind, right? So, all right. Do you have any questions? Should I go back? Yep. So this is comparison between the secukinumab, which is 17 versus 23. So works early. So look at the green one, works quicker, but it drops down, right? While the 23, maybe it will take some time. So that's what I'm trying to tell you. I have to tell the patient, hey, hold your horses, right? You will get the response. Just sit tight. So that's what I'm saying. So if you know what's happening with the medications, then you can tell your patients about what to do and what not to do, and then that will help your, patients. Yeah, that's right. Why it is like that? Yeah, because you see how they work. I'll come back to the work of the 23 is only very limited. Yeah, very small, right? So there is resistance, and then people have been trying low dose of the methotrexate with it, but I tend to avoid it, right? So yeah, because then I have a lot of other ammunition to use. But for example, here, yes, you can have a combination so that you do, and that's very true for the TNFs, by the way, because TNF is worldwide, So these are, their own countries. They're much targeted, more targeted than the TNFs. Mayo Hospital, Pakistan will do that. Yeah, I mean that's why the researcher was here, because we have new things coming up. These are the things that are being in the pipeline to do, and that's why that's the thing. The popcorn era of a popcorn biologics, because every 3-4 months new one, because they find something and they go after that, and they earn a lot of money by the way. So yeah, but yeah, you're right. I mean, this is a very valid point, Doctor. Yeah. All right. So the other efficacy consideration is that is it really faster response is really clinically significant? We say it can be significant. It's not like we're comparing with 23 is less, but it's still a significant amount. Let's say if their patient is good for PASI 75, then I'm good with it, right? That's fine. But loss of response specifically for the Cosentyx sorry, for the secukinumab, I shouldn't be saying those. Yeah. So that I will not pin down, right? Anyway, I'm the speaker for a few of them, so better not to. So what you can do if this happens, just a tip for you is that you can up dose. And we do everything for our patients. If it is off label, we'll do that. We'll increase the dose, decrease the duration, and that's what it is. If nothing is working, switch it. So this is like a trio that we generally follow, right? And it's not that it's not there, but it will be not 100. Let's say it's not 175 or 60. I'm good with that if the patient is good. So that's what we do. What are the common adverse events reported in phase 3 clinical trials? So these one will come up again and again so that you will understand how it looks. So if you see that, how you're compared, these are the side effects. So side effects are not much but still, these candidiasis that we talk about, right? for this one, and for this one, for the Brodalumab is also, I haven't written in here, but I think there's a new thing coming up, and there was something for the suicidal tendencies. And that's important for you guys to know, right? So, and then there's the HC and the secukinumab, they're all right. And it's also one of the things that we need to remember is that Candida infections for all, because this is the one that 17 plays a role in infections, right? So you're blocking them. You're allowed to have those infections. But the good point is that you can treat those, that's important. And but you should be aware of that. And then, sorry, and which one that you're using in here, you said? Secukinumab only, okay. Is there any chance anybody is competing them or coming in future? No, not yet. Chilling. Inshallah, I got right for all the purposes. So that means that's not very relevant to you guys, but candidiasis is more with the other ones, and there's a list of the side effects that you can see. So the side effects of the biologics could be if they're at the injection sites, and then we have an immune suppression kind of a relations, right? So malignancies in the long term, non-melanoma, skin cancers, not so much of a melanoma, but non-melanoma skin cancer are quite on a high rank, if you talk about that. And then you talk about of course, the hypersensitivity you can have with any of those in the medication. And IBD, the big talk. For the people, Caucasian people, it's a big talk. It is a talk in here. I still remember that we do have it, but Crohn's specifically, it's me. Sorry, yeah. I was telling you, yeah, sorry, yeah. And honestly speaking, I don't know how to close this. This is not my phone. So when we have this kind of a problem, we refer to Dr. Tahir Jamil, right? To keep the move on. Thank you so much, sir. So expert in that. I know that. I work with him in Saudi Arabia as well, over here as well. So I know. Thank you so much now. See, it works. Fine, fair enough. All right. So IBD is the big talk, and we don't give it to if there's a family history of the IBD or the history of the Crohn's disease specifically. But in all of them, you have to be very careful because they can actually build up. All right, so oral candidiasis is not a big deal. So, but they're there all the three of them, but not a big deal because you can treat them fluconazole or itraconazole. So there's a solution to that, right? So it's there, you can do something about it, the regular dosing or up dosing or whatever you do. So you be prepared that if you do that, you can, right? So that's not a big deal. So let's talk about the IBD. But that's what I was worried because in the Caucasian population specifically, they're very, very common, right? And so these are the IL-17 ones. They're all contraindicated, and specifically BRODA. And the BRODA has the other one, suicidal also. So I don't think so that's my favorite choice. And if I am, examining my patients and offering, I would examine some. I will do ICSI or BIM probably, but not that, right? There was a case, there was a study, a whole study, and then the papers causing avoid patients and having a fungal yeast infections. But again, I tell you the truth, they're more concerned about the psoriasis, and you're also concerned with psoriasis because of the cytokine release in the body. And specifically I've seen a few patients after the COVID as well, so because it somehow unmasked, I don't know. If somebody knows, please share. But I've seen quite a few one that they have started there. So maybe that's the push up and that's the trigger. We don't know, right? So, and then you see that the adalimumab, it's down on the list that is actually a treatment for the Crohn's disease, right? So, and so is the other ones, the 23 ones. So they are good to go, but not the 17. So we are still on the 17, right? So that's how we deal about it. So that's what it is. Or with even the AK, ankylosing spondylitis and all that stuff, you have to avoid it, and that's okay. So then we going to the IL-23, and then we're and then just want to put this here because the other stuff that's JAKs and the ticks, they're all in the membrane. So these are the small things, and they're in the membrane, and they can cause a big difference. But they have specifically for the JAKs that I must say that I'm pretty concerned about few things. Is MACE, which is the myocardial events, right? So that's important. Infections, MACE is important for them, and DVT. So you have to be really, really careful with them, but they give wonderful results. You have the tablet and it's oral. the Rinvoq, which is UPA, we call it upadacitinib, oral, but it's not for psoriasis yet approved in Canada or anything, but some form of psoriasis, we'll talk about it. Maybe it will come there. And the TYK2s are new ones, but they're not so much, they're still in the pipeline. But we're talking about this, IL-23, which is receptors on the receptor. So these are the IL-23, risankimab, tilrekimab, and there's one or two new as well coming, already been in the market, but phase 3 not yet approved, right? So look at their dosing. So beautiful, huh? The last two specifically every 3 months, like ustekinumab, like Stelara that you see, so every 3 months. So ease of dosing is there. So they're quite nice. They're quite benign, and this look like that. Some things are there, but not a lot. So again, a lot of pictures. Forget about it. Their efficacy, this is a head-to-head comparison with the nidelcamab with the secukinumab. That means IL-23 versus IL-17. So you can say that the brown one is the one that we're talking about, IL-23, right? And again, the same thing that we discussed earlier, quicker response, but long-term, But sometimes, the delayed response bug your patient. So you have to really select the patient population for that, right? Which patient? And that is why treat to target, okay? So always remember treat to target what the patient wants and go ahead with that. So there's no right or wrong rules in here. It's just that what you need to be aware of how you spend your time in picking up your biologics for the patient, right? And then it's a Skyrizi. This is my hot favorite, by the way. Skyrizi, I give Skyrizi and keep my eyes closed. Very good. No, nothing, no IBDs issues, nothing issues. And the patient gets few needles and good response. And the government pays for that in Canada. So that's also an important thing, right? So again, same thing for long-term, a very busy slide. The concept is the same. So I'm not spending this time much here. Head-to-head trials again. The tall ones are the 23s, okay? All the tall ones are the 23s. So they stand out. The real world data, yeah, patient adherence is excellent in the 23 because they're those apart, not like 2 weekly, they always have it a week's apart, so they're 4 weeklies minimum. 8 weeklies is the one, and the rest of the two are 12 weekly after the maintenance dose, which is quite an efficient thing to have, right? And again, no worries for the IBDs specifically. And so discontinuation, why then they would discontinue is because they do have a slow response, and sometimes the patient don't respond to them. So high BMI. High BMI means what? High BMI means that you need a lot of medicine to have those blockade of the cytokines, right? So up those and see how they go, if they can afford right now, or bring them closer, So you can definitely do that. And that's off-label, discuss it with the patient and go ahead, right? Sure, yeah. Yeah. Well, they are much, honestly. They are the same side effects. You see, what are you doing is when you're updosing it, you're trying to cover those with the leftover, right? So I'm talking about this because they're they're for the antibodies that they're just trying, they're not going anywhere else, right? So they're just trying to block those specific antibodies. So we haven't seen much of the side effects. Of course, no. What I'm saying is, but they're not doing enough work because some of them are left over. They're not being, that's the concept that they're talking about. The updosing concept is that because we need to go back to the basics of the drug distribution in the body, which depends on many factors. And one of them is the BMI, but they can be other factors as well, how it's given, when taken, timing, and all that stuff. So that's kind of recently I went to the Pillars meeting, which I owe my, slides to them. A lot of the data is from there. The Pillars is experts in the Canada. Every year they come together, and they would talk. This talk was also there. Is that there's a lot of stuff when you talk about upgrading or closer dosing is what is actually not increasing. It's a very good point, actually, not increasing the side effects, but it is actually covering the rest of the blockade of that, antibody that we wanted to do, right? So there hasn't been any reports, but again, because they're off-label use, so they don't come up into the market. Yeah, so that's true. I mean, they can be a possibly technical, theoretical risk, but that was being defended by somebody over there, and that's what I heard, and then I will share. But it's a very valid point. Yes, it can be. Then there's a risk of so many things, even in the normal dosing as well. right? Yeah, you're right, because when you're talking to the patients, you do have to tell them what you're giving and what risk they are having. So they took that risk, and then when you tell them, hey, we can try this. If you have this, come back to me. So be close follow-up, I think. That can be one of the, that's what I do actually. I have a routines, but then if I do something out of off-label, then, you know, either telephone or call them back and then see them often. It's a very valid point there, yeah. There's a lot of gray areas in these. Yeah, and that's why I came here to share with you guys so that you can also give me your insight. Yeah, exactly. So my experience, yeah, of course, I like my Skyrizi. I like prison. It's not that because of anything, because of the drug company, but it's definitely giving me a good results. But of course, there are a few patients which do not respond to that, and I have to move on, right? And for the same reason, very, very happy patients, and only this one of the patients all cleared, and then this spot is there. So what I will do for this spot? And she's worried about it. What do you think? Intralesional. Oh, wow, that's very good. Yeah. If she's needle phobic, then yeah. So I'll go for the topicals. Yeah, you can combine them. That's great. That's one a good protopic or Dovabed or whatever is available. You can go for the topical. So you can combine them. That's what my message is, that you can combine them with little spot left and it's bugging the patient. You can always combine the topicals with it. There's no contraindication to that, right? So, and that's what I did actually. You can tell them there's a new cream coming up. Or you can give the foam treatment for the Enstellar, which is different than the. No, I'm not saying deceiving the patients, but sometimes it works with the psyche of the patient, you know. So you really have to understand. Yeah, I mean, again, you know, I don't know. Really, we don't know why some people also respond on that. Not only because of the pharmacokinetics, it's because they don't respond to IL-17, they go IL-23 and it's responsive, or the vice versa too. Although, because if I have some patients with a rheumatoid arthritis or something, I'll go for 17 rather than going for the 23 because it works in that pathway more better, right? But so you have to have like other, but definitely there are a lot of variabilities. Yeah, please. Two biologics can be combined. Two biologics can be combined, yes. For example, we have combined a biologic for eczema and psoriasis. So dupilumab, Dupixent, and one of the IL-17. It can be combined, but what you're talking about in psoriasis, it's not recommended for two reasons. Because if you have two combined, then she's worried about, and then she's rightly worried about the immune suppression, because you're combining the two different molecules and the two different ways of blocking your immune system, then you're bound to have more side effects. This is not being promoted in psoriasis and biologics. You can have the two combinations, for example, the TNF with the methotrexate for a different reason. Yeah. But again, yeah, that's what I'm saying, is that you're thinking about, so that's why I've shown you the two different molecules. You're trying to have a really block, you know, so blockade, you know, you're trying to do one blockade. Oh, sorry, I'm sorry. I'll take it off my. So one blockade, two blockade. That's a lot of blockade, right? So we don't want to do that. So we haven't done that. And it is not promoted. In the pillars meeting, that was also brought up. Yeah, we don't. But yes, two biologics can be combined for different reasons. For the like a dupilumab, Dupixent, and the for the atopic dermatitis and for psoriasis. Okay, so yeah, that's been done, that's been proven, but not like the two. So let's say 23 and 12, 23 and 17 together have not been. Yeah, no. So that will, because even when we switch, we have to give a time. There's a switching time, because then you're at a risk of having more immunosuppression than anything else. Yeah, so that's a very valid question, though. Yeah. All right. So safety, I consider they're pretty safe, although you can have like all these listed. And remember, patients are not your trial identities, okay? They are different. So this is very important, because whatever that you read in the papers, they are different because the settings is too different. You have selected a set group of a patient and done the trial. So when you're seeing the patients, they are not the trial patients, okay? They are your patients with a lot of other stuff which you do not even know. Because you have selected a patient for example, RUDA or ICSI or whatever, with a good renal functions, with a good liver functions, but you don't know this patient is going, when you are on the medications, maybe something else happens and you don't know. So remember to keep an eye. That's why, I give an importance to them, but of course, it's important that stick to the major things. And tuberculosis is one of them. In general, we haven't talked about it. We took it for granted, but it shouldn't be taken for granted because you should do a proper checkup even before methotrexate. How many of you raise your hands? Do you do a TB testing before methotrexate? No one. But I agree to it. It's because I want to treat my patient. So I will do the methotrexate, then I will do the Conti and do the X-ray, whatever. I will do that. But I will not stop giving the patient to wait for that results to come back because that will delay the care for my patient. So yeah, you should be doing it, but we're doing it. You treat the patients for that, right? So but you should be having in the back of your mind, oh, it's in cough, and then of course in here, cough sputum with hemoptysis or whatever. So that's important things to consider. And similarly, the non-melanoma skin cancers. And I've seen, I still remember the worst of the skin cancers I haven't seen in the West. I've seen in here. The squamous cells, which is destroying everything and coming to the clinic and sitting in front of me. I've yet to see this in the Western world because they're more aware of that probably, although it's very common over there, right? And having a melanoma in the eye, although I still remember there's a patient in here for the eye and having a problem. So, for melanoma. So what I'm trying to tell you is that we have to keep our practice, but have to keep all these things in mind. I'm not saying that I will disregard saying, hey, IL-23 is very good and it's only giving me, it's no problem with the IBD and I'm liking it, it's fine. It doesn't have all those infections and those side effects. We do that. And I'll talk about it in a few while, right? And so these are the three ones that I talk about. Tildra and nothing to be, I don't think so there's much difference between them that you need to remember. But I want this, a minute in here, is that I want everything on this corner. There's a good PASI and a less side effects. So these are any side effects, these are the severe side effects, and I think this is the long term or the PASI 90 that's there. So we want everything in here. We want everything here. We want everything here. So the 23s are here. 17s are also here. I'm not saying so, but the 23s are here, but TNF alphas are not here. So gone are the days when you think first of the TNF alpha, unless that you really have to, then you should be doing. But I'm not saying that they're off the market, but they're good, but they have a lot of side effects. Be aware of it. Right? All right. So IBD, we talk about they can give actually you can have it in the IBDs, and that's why they're good. We talk about and they're for the children. So there's a set of population. So the pediatric professor is also here, right? So the children, they're still in certain phases that they'll be coming in there. So, but they will be indicated soon, hopefully, but they're in the pipeline. So it's a word about that. And for the pregnancy, if you have any questions for that, I always tell my patients and take their own decisions that we haven't had anything that is known in pregnancy to causing the troubles, but it's up to them whether they want to continue or not continue, because that's a major decision, right? So we can't say, hey, go ahead with it. Oh, you can say that. You can tell them that maybe it's okay. A lot of my patients said, but the data is not suggesting. That's what they respond to. And the nail and the scalp psoriasis, well, so they're good, IL-23 is also having few of the, probably IL-17 is also, I remember that the Cosentyx when I was the PI is that we had response, but not a drastic response. But it's a good, so biologic is still good for the things. What is your, because you guys use secukinumab a lot, right? I mean, that's the only, you don't. Anybody uses it? It doesn't work. Good, great. So thank you very much for that, right? So, but these works, I've seen the patient, my patient was NAPC 34 to NAPC 7 in only 6 months, and he was rocking good. He was joyful. All right. So, and then, so that means that if you have a patient, see, 44% have palmoplantar, and palmoplantar is a separate entity. You know that it's a difficult one. It's a difficult one to treat. Yeah. So palmoplantar, nail, and the scalp all together, and such a good response with IL-23. So don't take me and don't quote me that I'm an IL-23. I promote here, no, because they give good results. That's why I'm just sharing with you, right? So, and yeah, that's why my first patient was also the risankizumab, right? Comprehensive and coverage and all that, and it's auto injector also, and yeah. That's good. So safety in pregnancy, as we tell, that there is no safe drug in pregnancy, they need to say, but these are relatively safer. Okay, let's put it in that way if you can It's just a way of the words to saying to the patient, right? Or to ourselves then. All right, so disadvantages. So we talk about good advantages. What are the disadvantages, right? The disadvantages would be what? That achievement will be delayed. So some patient will get bored. But you say, hang in there. Maybe some patients are impatients like me, so I want a quick response there in 4 weeks. Okay, I want that, and so it depends. That can be one of those. And so, and then again, they are, because they're distant apart, so they are yet to give 3 months, and then the 3 months, and the 3 months. So you just wait for at least like 6 months dosing to see. So primary failure or the secondary failure, you know, within the 3 months is the primary one, and then secondary is layer one. So that's important. So for the IL-23, the take home will be all good, efficacious wise, safety wise, and all the population that we see. The convenience is very good. Slower pregnancy, we don't know. And well, we're not so sure but whether the Tilra will be out, but we're yet to see this in the market. I'm not very fond of Tilra, but yeah, just keep an watch. There may be some issues that are coming up with it. Okay, snapshot. Of course, yeah, we have talked about it. This is, yeah, disadvantage, big disadvantage. We can't give. But not pay, even better is the US, because US you can straight away go to the for us, we still have to follow topicals, photo failed, then two immunosuppressants failed, and then bio. And then the bio also that they do have their supportive insurances, secondary approval. If we do not have it, 3 months or maybe more, maybe no. Well, I don't know. We'll just have to see. We'll have to see, right? We'll have to see. All right, guys. So this is a 48 years old male. And by the way, the FDA and well, we don't have to talk about it, but it's a lot of pharmaceutical, you know, imbalance there. And it is a lot of stuff that we, and in the pillars meeting again, the Canadians are not very pro-Americans, by the way, just to let you know. So they have talked about it is that the FDA, you know, when they sit in the FDA, that's a government profile, what they want to implement. Nothing to do with the patients, nothing to do with whatever whatsoever. So that's why when you have a black box warning, if you remember the Accutane black box warning, if you remember that, even that long, you know, and we said, oh, this is not there, you know, and all the calcineurin inhibitors, we have a black box warning, and that was a question raised by the Canadians, and that was I came to know about like a few months ago, is that these patients were already having those kind of a malignancies, and so take the black box warning away, but they did not, because it cannot be done, which is everything which is done in the FDA is like, you know, a solid rock. Anyway, whatever. I'm not an FDA, but you know, my brother is as if of just a conflict of interest that he is the yeah, he has something to do with the FDA, so I should be better keeping quiet, right? So, all right, so male, 48 years old, pre-treatment scores, PASI 20, DLQI, bad DLQI. You know that a DLQI 10 and above is something that we should be worried about, right? And the body surface area and IgA, quite relative though, you know. To me, it looks like more thick. Somebody might say not so thick. 2 to 3 is always a 2 or 3 margins, keep them there, you know. So no comorbidities. He's no comorbid. High BMI. Okay. Then he was treated with TNF alpha, adalimumab. And then what happened? Post-treatment scores, well, from 20 to 5, 12 to 6, 13 to 2, IgA to 3. So what do you do? What do you do? Tarek Jamil will continue. Anybody else will continue? Raise your hand. You will continue. You will continue. May I ask you why you continue? That's just a question. You. Okay, fine. So you want to continue until what time? We've read so much. I've talked so much about it. You have to come with some answers. Otherwise, I'll go under the chair and hide myself somewhere. Well, he's giving me the chair anyway, right? What time? Excellent. So treat to target, back to basics, right? You had some targets with him. He wants that. For example, he said, no way, doctor. I don't want that 5-fussy. I don't want this, Not 2BS is not important because it's on my face and I have an audition tomorrow. Or let's say he's somebody really celebrity, right? So then you think about changing? You may. You may. Why not, right? But of course, you will tell him that this is working for you, right? But you will also tell him that in the long term, it will not work for you because you can have an antibody, right? TNF there. And you can have those things. And you can have a separate discussion to that. So that is very important for especially the youngsters. It's very important that I'm not saying I will also not change for him if he's okay with that. I'm okay with it, but I'll keep an eye on him, right? And keep an eye for the TNF alphas, and that's how it is in the real world. That's what we do. Right? So yeah, I would go for A probably. We're not with the those escalate. Okay, if she said that he really wants a BSA 0 or something, and I've given him a regular dose, I will still try to do the updosing if everything is fine. Right? So I do the updosing, maybe a little closer shots. I've done that before. So that I will give him a try before I switch. Full-fledged trial, right? So that's important, right? And for the topical ones, as she said that, okay, or he said that you can use a topical, right? It's a small one area left, not on the face, the legs and something, yeah. You can add on a topical conveniently and see how it goes. So it again, target to treat, right? That's important, right? All right, so yeah, it's almost clear to clear, and that's what we talked about. We don't want to rabble around. The Canadian data is something which is switching, discontinuation, and dose escalation as the, that's what I've been comfortable doing it. Interval change, even it's off-label use, because for me, my patients are very important, right? So that's the more important thing. All right, so this is a very important slide. See, I need like a few minutes of your concentration in here because these are TNF alphas. And that means that we are having a yes to the patients who have treatment change. So the purple is a treatment change, okay? And the bluish, so this is the purple treatment change, and the bluish is not. So, and then the change is, so it's not very clear over here, but maybe a change inside, and then there is because of the side effects, and because of then we do the change in interval shortage, okay, and then switching. These are the three things that we discussed, right? So this is for the TNF alpha, see? And then if we do about the IL-23, 12, 20, ustekinumab, right? So what you do is that it is still there, but it is less than TNF, okay? And this is the side effect is getting this shrinking, if you see that, right? And if it is IL-17, it's even lesser, right? There. And what about 23? Look at that. So they're very comfortable in having, so they can be a switch in them, but not switching to the others, and the dose escalation. And look at the side effects are almost non-existent. So this is how the quick comparison of the things that are, around you there. Leave it there, right? So the British Association's guideline also escalation treatment. They say if you really want to know, the talk was to escalate, right? So you can escalate every week, or you can every other week to weekly for the adalimumab. And so you can have either the change in the week or the updosing. The similar concept, but this has been validated by the British Associations of Dermatology too. So I'm not speaking only on the behalf of the Canadians. It's also the British are doing the same, I don't know, right thing or wrong thing, but there's no right or wrong in here, right? So how comfortable are you dosing, optimizing a biologics? Have you done that, any of you? Front. Well, the second ones have gone to the first row, so now I'm targeting the first one. Have you done it, any of you? Optimizing the dose of off-label use? Nothing. So you can think about that, That's one of the things that you can think about before you switch on and do. And discuss the dose optimization. So the patient is very, very important back there. Similarly, this girl is IL-17, okay? Clears completely initially and recurrence. What you do now? So you don't optimize first? Optimize first. Higher, closer, see how it works, and then switch, okay? So give a benefit of doubt to the patient because it's not easy to switch as well. Anyway, you don't have anything, yeah, that's correct. But you may have something. Pakistan is ever changing. I know Pakistan very well. I'm a Pakistani, so it can change in one day. Okay. All right. So for this patient, I can say I will do the updose. I will not do the no change. I will not sit on it. but I will do some escalation or the interval, you know. So this is how you deal with your real world patients. Yes, sir. Oh, cyclosporin is out, na? Cyclosporin means that you are having a methotrexate is also one of those, you know, suppressants. Oh, hogi like secukinumab PCI because they want to run it, you know, they want to run the show. That's why, but it didn't work through. Because of the reason, it may work, but because of the reason, because there are newer, better forms are available with less side effects. Probably for them, but for us, yes, you can. You can have a trial and I can. Methotrexate. मगर क्यों क्या किस वजह से बेहतर हुआ होगा पता है antibody production they're not very well known for them but yeah it's practically a possibility तो publish करें ना ताकि फिर उसके बारे में मैं भी बोलूं कुछ Honey, that is a possibility but again at the risk of some immunosuppressants yes sure. Yeah, this is your personal experiences expert opinion yeah I'm sure but there's still a case report they're not a big Of course there, but what I'm saying is that if you have a trial which is running like thousands of patients and your experience, expert opinion is there. So we know this is important because they never get published. You know, it never gets published. That's the problem with the publication. That's why I don't really jump on the publications because what you have with you, it's never published and it worked for your patient, right? So what works for your patient is number one. That's very important, right? Whatever that we are dealing with and giving you the ideas what's happening in the world, but doesn't mean that you have to follow strictly this one. Give this the idea and build your own patient clientele with why you're doing it. So don't forget the why, and that's what I never forget. Right? So, and then I get into problems as that, right? So you always get a problem, but then you have to deal with it. Right? All right, switching is important. We talk about it. We don't talk about more. Everything which is in here is on this end is good. So 23 is good. This is good. This is not bad. And if you have this before and you're reusing it, you have it and reusing it. Okay, that still works, you know. Having sometimes maybe that you're right that the antibody clears off and all that stuff. I don't know. No, but that's something that we may look into that. That's a very valid question. Right? All right. So long-term safety data, as I know. So how comfortable you changing? You should be comfortable now of exploring this in that way at your comfort level, how you're comfortable with, and do that. And definitely discuss the changes of the treatment with your patients. That's the more important thing. So, and when you do that, choosing to switch, the efficacy, that's what the question was in the bio-experienced patient. The comorbidities, so it's not the drug distribution. The second thing was the comorbidity along with the weight that's there. And probably sometimes one patient and we did everything for him and then we were thinking of hey, whether he's really taking the injection or not. Really. And then we told the patient to go to or nursing somebody to do the injection so that we get the response. So sometimes it's, you know, patients also in here probably they can't afford, you know, to get a second one and they'll tell you, hey, I'm taking it, it's not working, you know. So those are the things that they are real world challenges. And when transitioning between them, generally a month is okay, but it can be lesser than a month. 2 to 4 weeks is generally the thing with the switch over. But it's to be or not to be, to switch or not to switch, and to have a distance and interval is still a gray area in the field of the psoriasis. People can start off with the next week as well. They have done that, right? So, but again, the risks is there. If too long, then the disease will come back. Too short, immunosuppressants. So you have like the two evils are already there. So you have to choose which one you have to pick with. So targets, treat the targets. That's what we learned today. Or and do whatever that you do for switching. And if it is not achieving, then go back and talk about it, right? So that's pretty much it. We have not yet done. I mean, we've done this. The biologics is just a most important common safety concerns. This is I really want to have a look at you. So you can even take a picture. So I'll this one and key safety concerns. 17, we talk about IBD again, right? And for this IL-23, we talk about the no IBDs, but we talk about good Skyrizi probably. Look into that. and hypersensitivity in all. We have done that. We have done it all. So that is a no, big no to anything. But the active Crohn's, if it is active, you cannot touch broader. But suicidal tendencies do not touch broader. Okay, that's important, right? But disease slide, but just to tuberculosis and TNFs is, you name it and it's there. It's the prototype of everything, because as I told you, all the cytokine, TNF is in every inflammatory marker. So it's a big response, a big thing happening in the body, right? So, but that's one thing. And the tuberculosis is still TNF, this one. And also think about the infections with the UPA, which is JAK stack. So infections are also important, in addition to the MACE, which is the cardiac myocardial adverse event, or the Rinvoq or the upadacitinib, which is coming up in there. So I hope that you're somewhat confident in doing whatever that you're doing, hopefully, that I can share with you, right? And so what we will do for this, I will not leave you so soon, don't worry. Hang on there, hang on. Okay, this guy is IL-23, 6 months, and now his skin is clear. But then he's coming to you, sitting in front of you, and he's saying, I have a couple of sinus infections, and I think it's suppressing my immune system. What do you do with that? And this lady, she said, okay, somebody, my best friend has Crohn's, and when he was given the TNF, I'm not taking TNF. He developed lymphoma. I won't touch one of those. What would you do? I need answers. Okay, let's talk about him. What you do with this one? Wake up, guys. What you will do? अब तो मुझे इसके अंदर जाना पड़ेगा, कोई जवाब नहीं देगा। What will you say? Will you tell them it's not an immunosuppressant that we're talking about, right? It's not a full immunosuppressant. And you can have your own analogy. Just say आपका patient, I have my different patients have different analogies. They'll say, oh, this is the whole umbrella that immune suppressant like methotrexate, but this is only targeted. It's not having an immune system blockade. And then you can think about it. Give him a next time, give him time to think. But tell him that it's not an immune suppression knocking off, right? So that's, unless it is TNF, right? Of course. काउंसलिंग करते हैं, चलिए काउंसलिंग करते हैं। और इसको क्या कहेंगे, लिम्फोमा को क्या कहें जी? चले ठीक है, आप दे दें, अगर पेशेंट बेचारा अफोर्ड कर सकता है, प्रोबायोटिक करना कुछ नहीं है। चलो दे दो, नहीं है नहीं, चलो ठीक है, प्रोबायोटिक दे देंगे। Great, excellent. इसको क्या करना है? How would you do this lymphoma? So they say counsel him and tell him about the immune. This is not really an immune. He needs something. He needs to be aware that this is not a totally immune suppressant. Right? Well, what about this women? What about lymphoma? Would you tell him that the lymphoma is because of the TNF? We'll tell him no. Right? But then you say, उस patient को होगा lymphoma, तो फिर उसको TNF दिया, the problem है. Right? So that's why it's important for you to know what's going on, so that you can tell your patient. And of course, convince them, and of course, make your own decisions of what you're supposed to give it to the patient. So, but remember, your expectations, as we talk about, is different than the patient's expectations. Just be aware of their expectations. You may not meet it all, but you can address them. That's important. Right? All right. So we have done this disclaimers and all that. These are the new things, by the way. Somebody was asking, well, not the new things, the number of the patient years that they have tested for, because somebody will also tell how long they have been giving to you. This is a very common question. How is it? So you can tell them how much data that they have and all of these. So we have discussed with all these, the funny slides, and key points to discuss with these patients would be, we have already discussed and about that. I'm done with this. So my first part is over. Do you want to have a speech to that? This is the one that we're talking about, right? So we'll talk about the immune modulation as opposed to the immune suppression. So talk about immune modulation rather than the immune suppression. And then speak to the baseline cancers and inflammatory disease, then you don't, associate, they're not associated with the therapy. So that's what you need to know, that's what you need to give. Anti-TNFs and most of the side effects, if you know about them, you can tackle them. And you can be aware of them, so you can take it off, back off, change differently, and discuss. So you need to know, as a physician, that's your responsibility to be aware of whatever that you have to. All right, so it's more than a summary, I must say. That's not all. If you're okay. What do you want, guys? Thank you so much. वैसे चाय ज्यादा अच्छी थी लेकिन इट्स ओके, थक गए ना अब आप लोग। अच्छा एक केस कर लें फिर चलते हैं। जा साहब आज बुलाया तो अब भुगतना ही पड़ेगा। अस्सलाम वालेकुम। All right, what I do, I just want to share with you. So before that, where is my slides by the way? Is it here? अच्छा इसलिए लगा दिया। What I do is that and it's a question, it's just a provocative thing, and how many patients that you have in on, because this is what we do, what we have done with one of my colleagues is that for all the biologics, whether it's atopic or it's eczema or it's psoriasis, that we see, we ask that how many patients are, we are gathering our data as well to publish, but we'll talk about it. But what we do is that we devise something as like a cheat sheets, right? So we're more than happy to have these. So this is like psoriatic assessment. So if I have in front of me, then I would not, because sometimes when you're talking to the patient, you miss out a thing, right? So when there's some kind of a template there, then it's easier to do this. So this is how that you do, that all we talk about is to know how the extent of the disease and the medical histories and the routines and the tuberculosis that we always do. I think you guys should also do chest X-ray to see the latent one. And quantiferon, if you can do, it's very expensive though over there. I'm sure it's here expensive as well. So that's important. I have not done an HIV serology ever. Is two reasons, or one reason I can say, is that the HIV is actually now in the West is a treatable disease, and the people they are living a normal life with the treatment. So and their CD counts are generally well dealt with. If they're known HIV, then I do see the CD counts, okay, and how's the activity, but I've never done, and it has not been, actually, you will be surprised, it's not there in any of those biologics, pre-workups. And actually, a lot of biologic pre-works are quite clean. They don't want you to do a lot of stuff, right? That's what they say, but I still do it. I don't know. You feel comfortable, it's your comfort level, do whatever, yeah. Because it's very endemic, because if it's a latent, it's the TH response that they do. The biologics, when they're hitting it there, they are having the same TH response, TH1 that provocate, and so you can have the granuloma, coming it out, doing wonders for you. So that's it's because of the immune hitting response. Yeah, that's why we worried about it. So very, very question. Great. Right. So we actually don't have any recommendations. This is what the fact is, right? But we're still doing it. So it's also saying when necessary. So this necessary is quite a gray area. And the patient will come up and they say, hey, you've done the TB testing last year, and now, it's positive. Why didn't you do it again? Because you never said, you said, I need to have a clinical, reevaluation of the patient or any symptoms. So be aware of those things as well. If the patient is coughing and having troubles, weight loss, and night sweats, or whatever that you can do for the tuberculosis, keep an eye on that for that. So it's not being left out. If we haven't talked about before, I need to see that we are definitely having it in this one. So right follow-up, there's no right and wrong, but that's what we do. If I start a biologic, I see them in 3 months, okay? If they do good, 3 months, maybe more, depending upon the patient's anxiety also, sometimes 6 monthly would be good. So the time that they have anything, if they have anything change in their situations, go back to 3 months. Okay, so that at least and at least that even the IL-23 is after 3 months, you're going to jab them. So at least give them some time. So it also depends on what you use. But 3 months, this is what we generally do. And I generally do not repeat a lot of the LFTs and creatinine also if everything is fine at the baseline, unless there is any need for it. So we always discuss on the monographs and tell them about it. And you also always discuss among yourself as if you're doing it, right? So the colleagues, your colleagues, make friends with each other. That's important. What is reasonable and what's your comfort level is very important, okay? So this is what we do. So just a quick thing is, and actually the most interesting thing, history is important. Labs are important. So I'm having a stop, proceed, and go sign with this one, okay? So what do you do with this? So you're having an IBD, then you should be careful with IL-17. You have a heart failure, forget about TNF. Okay, if you have renal disease or liver disease, so I haven't discussed with you the JAKs, but The JAKs are the culprit. So you have to be careful with the liver disease at least, right? Do you have any JAK inhibitors yet? Yeah. What do you have? Upa? Upa. Rinvoq, right? But what's the name? The trade name? So no. Okay, forget about it. So Tofa, you have Tofa. Upasitinib is Rinvoq, right? Yeah. So this is something that then you need to be careful about, is because it is amazing. And in eczema, you give them, and then within a month, the patient is jumping, coming to you, and then you would like to call them back in a month, no problem. All right. So clotting wise, also you have to be careful. And the connective tissue disease, of course, the TNFs and the multiple sclerosis TNF. So this is your one thing. And then about the malignancies that we talked about. So there is no red blocks. So this is also a gray area, because there's a recent guidelines published for giving biologics in malignancies. So it's generally, what I remember is that if you have any organ, cancer, and it is in remission for 5 years, no problems. That's what they say. But there are other things as well, and the melanoma is a big talk, actually. Melanoma is a big talk. You can look into that. But as far as we're concerned, the JAKs are the issue with CNS. Our so-called benign 23 and 17s are still prevailing, green signals. And infections we talked about, but HSV also, we don't have it, hepatitis, and specifically hepatitis B. There's something that we need to look into, again, the two culprits. And that's important. The HIV also the same. I mean, because I haven't used a lot of TNF, I do use a lot of JAKs though. And that's for the atopic dermatitis. But we don't do HIV as a regular routine, right? Although you can find, like, if you wish to, it's extensive also over there. And then we have to send it to the patient. We have to ask the consent to the patient. It's kind of a disturb their privacy, But it's okay. You have to talk to the patients. You have to talk to the patients. This is an important thing for you. And you take your permissions. And I'm going to talk about these special private issues. Are you comfortable with it? And then we talk about it. Right. So let's discuss the bottom. Vaccinations are important. They beat Shingrix. Okay. I've got a lot of patients with zoster, and that's really, really troublesome for them. So yes. I think we've done that before, remember? Right? Again, it's the TNFs and the JAKs. All right, so live versus non-live. So remember that Shingrix is not a live vaccine, but you want to have a first dose at least 2 weeks before you start off the biologics. That's what you want, because it's 2 doses, right? Second is 2 months apart. And sorry? Pneumonia is more than 65, but it's not. Yeah. So generally what we do is that more than 65, we have a regular routines over there, right? So they're already getting it. I just want to make sure, but it's not being talked about well. It's still because of the immune, again, the immune, the immune system blockers that's done. Okay, but that's what it is. In fact, inactive vaccinations anytime, and these are the inactive vaccinations. But more important thing is the zoster, 2 doses, at least two weeks before you start off with it. So be comfortable doing that. That's important. That's there. That's there. You still have it. You still have it. Because then you are changing the immune system, right? So we were asking for troubles again. Last challenge, probably. Last one, and then you can go and eat, drink, or do whatever. At the time, I don't know. You're stuck up with me, guys. It's fine. So this patient is a rheumatoid arthritis patient, okay? And so he developed, he was given the rheumatoid, for RA, he was given the treatment for adalimumab, and then he developed the psoriasis, and then he was put on brazilcamab for psoriasis. So I'm running the story short. He's a rheumatoid arthritis patient on the methotrexate. Methotrexate not working. Rheumatoid arthritis rheumatologist put him on the TNF. He developed psoriasis, and then he was put on the brazilcamab. Then we got him. Okay. So, and he was terrible in the sense that a lot of the patients in that part of the world, they go on the disability plan. So, I was thinking, how can I go? But I don't know. I cannot, right? So they get a good, They have nothing and they just say, oh, the psoriasis is giving a disability and they're getting it on the disability plan of your whatever taxes that you're paying. But anyway, so work is affected. He was a manual worker and he really wanted, and his affection is actually on the hand and the feet as well, or the body was there. It cleared off because he was in the Gazelkamab, which is one of the IL-23s. And then he's also having a lot of depression. So fluoxetine, the antidepressants are like the M&Ms there, you know. So every third person you would have an antidepressants there. So you need, and they have a lot of side effects, especially seborrheic dermatitis and all those stuff. So you see a lot, and the patients, you know, don't know about them. All right, so methotrexate, adalimumab, psoriasis, Gazelkamab, hands, feet, body gets better, hands, feet, the problem. The rest of the stuff is over here. CCP is still high. He has a rheumatoid going on. Psoriasis there, probably psoriatic arthritis, we don't know. So that's what it is, right? So you see that how thick the nails are and how thick the feet are. So the diagnosis is the hypertrophic arthritis. Gazelkamab dosing change, closer by higher dosing is not improved. What are you? What's happening here? Is it psoriasis? Yes or no? Come on. So what is it then? If it is not a psoriasis, what are you thinking? Tinea, mycology negative. Good thought. Excellent. Right. Because sometimes we just immunocompromised patients, anything can happen, and we forget our basis. So always consider that you can have like different forms of the common infections. So the uncommon forms of the common infections are still common than the uncommon diseases. That's what it is. Sorry? Writers. Now, why would you have writers? He's already on a methotrexate. He's already on the Gazelkamab. Well, Gazelkamab is also probably best is nothing. Veruca. So you see, what about the nail and the feet and the hands? Look at that. Who say yes? Okay, let's do that. Who say yes? Still can be a plaque psoriasis. So what do you do next then? Tinea negative. Okay, what else? Local steroid. Okay, he said to give the local ILK. Okay, can be a very good thought. Perfect. Would you like to know what it is first? Before, take a biopsy. See, and if you see the biopsy and it's psoriasis form dermatitis, what is this then? Excellent. So sometimes you think about the paradoxical psoriasis, you forget about it, but we do see that, right? He was given adalimumab, and then after that, the psoriasis started. TNFs are not the only one. Even the Gazelkamab is being reported to have like few case reports, and there are few others. I think IL-17, IL-23, a bit of everything is being reported to having paradoxical psoriasis, which is not a psoriasis because of upregulation again of the immune system and all that stuff, right? So it is not, it was a paradoxical psoriasis, right? So in addition to this one, so the treatment is different. The treatment is upadacitinib, and that clears you off very quickly because it is one of the stuff which is eczema. So this is what a lesson to learn, okay? So don't forget the paradoxical psoriasis, and that's important. I don't want to go about that. So this is we all discussed, and so this is the response of IL-23, 12. Forget about it, what the patient is. But the targeted psoriasis treatment update, we always talk about 12, 17, and 23. And the rheumatoid arthritis have the similar pathway, so you can go about that, but they don't like a lot of it. And yeah, so forget about it, right? So this is the same thing that we talk about. I don't want to lay the message of rheumatoid arthritis, same thing. Selecting a different biological is important. So other thing that I want to say is for our case with the biopsy, other things, the first thing is UPA, right? And then you can try something else. Yes, you can try all of these, if whatever that you have, right? But the main important thing is diagnosing it. Getting a biopsy is extremely important. It takes another transition between the psoriasis, switch that we talked about. Transition between psoriasis is a prevalence. Okay, fine. Primary failure within the 3 months, 8 to 12 weeks. Secondary anytime long term. And you have to find a reason why you're switching. Think about it. And you have to decide with the patients if you're doing it, right? you want to go for the same class or a different class, again, you can decide from that, right? So, washout to be or not to be, it's all up to you. Two thoughts, two people, two groups of thoughts is that what they do is that if they do the washout period of a month, then again the psoriasis will come back. If you not do it, then immunosuppressions and infections. So this is one of the journals, the European dermatology. They say if it's this is how 1 week to 4 weeks. So 4 weeks is a separate window if you want to not remember everything, but it also depends upon how they work and how they clear off out of the body. So that's what the washout period that you do want to achieve that. Transition between the psoriasis, many things, cough, infections, immunogenicity. So be thoughtful of paradoxical psoriasis. And there's one thing more. There is a new thing, which is IL-17 also is getting the eczematous rhinitis. That's hand and feet. And also, so do not hesitate to get a simple biopsy done to find out what's going on in there. Well, the people can have psoriasis and eczema together, but if he's on IL-17, having eczema on the hand and feet, I'll get a biopsy because I want to have a treatment of that at one end. And many new things. When you use them, they will come over to discuss with the police and you find a solution. But don't forget to have a targeted treatment and think about what you're doing, why you're doing it. I think that's all that I want. You can have your team. If you don't have any questions. Thank you. Thank you. Thank you. कहाँ से क्वेश्चन आए? आप इधर हैं, इधर आ गई हैं, आपको कहाँ कोने में कर दिया इन्होंने? आप लाइमलाइट में आए ना इधर। फिर भी मैंने उसे कैचअप कर लिया फरहान। Biologics. जो कभी खत्म नहीं होती, वो आगे चलते समझ जाती है। पॉपकॉर्न की तरह का पॉपकॉर्न जरा सी देर से उससे रहता है ना, फिर थोड़ी देर के बाद हो जाती है। Newer. Question mark. Question mark civilized world. Yeah. But in the first world and the third world. Yeah. I think there are good. I am a dermatologist because I was trained here. Imagine करें कि इसके अलावा मैंने कहीं dermatology की training नहीं ली. So what I am is, and I'm proud to be Pakistani, that I worked there as a Pakistani. Okay, that's why it's. I never thought that I'm from a third world country, if ever for a minute, because the amount of the troubles that what we have in our, I must say, and they know what the troubles were. So the amount of the crushing and grinding and our, all these 4 years, I think that has made what we are today, and we are very thankful for that for our Professor Harald. Another thing that I was trying to focus was that the perception of the expectation. The doctors, even doctors, are different from the patients. Yeah. It's a big thing. Both of them would want to say you need to do something like that. They have to see counseling and spending time with them. It obviously the time we consultants as well as the working 200 plus patients every day. But just after that, 2 minutes. If you have a priority set up, what you need to do? Because ये बड़ी जरूरी है कि आप और पेशेंट एक पेज पर हो regarding the course of this. It's not a one-day treatment. उसमें चलना है और उसके साथ हमने मरीज को साथ लेकर चलना है. मैं तो अपने पेशेंट को देखूँ कि आपने और मैंने कुछ अच्छा इकट्ठे रहना है. तो उसमें हमने एक दूसरे की आपने मेरी हेल्प करनी है, मैंने आपकी हेल्प करनी है. इसलिए तो we have to. अच्छा, और लास्टली आई वुड से कि मैडम मैं पिछले 1 हफ्ते से मैं सो नहीं सकती. मैं रात सारी जागती नहीं हूँ. मतलब मैं अक्सर मेरी क्योंकि मेरे आई एम द कॉन्फ्रेंस के पर मैंने और डॉक्टर नाज़िया ने बताया कि डॉक्टर नींद की. आई एम सॉरी फॉर दैट, रियली सॉरी. लेकिन ऑन पर आपकी प्रेजेंटेशन में मैंने एक दफा ध्यान Thank you so much. That's very kind of you. The only thing that yeah, मेरे पास है. The only thing that I want to share one thing इन्होंने कहा ना कि हम मैं और पेशेंट जो है वो कुछ ऐसे साथ रहेंगे. छोटे से जोक है. वो एक बेटी की शादी हुई तो अब्बा ने कहा कि मैंने तेरे लिए अब्बा भी डर्मेटोलॉजिस्ट था. तो उसने कहा मैं तेरे लिए जो है ना ये कर दिया. तो वो बाहर देखा तो 4 psoriasis के पेशेंट हैं. तो वो सारे लाइफ जो है ना वो आएंगे और उसको उसका रन करेंगे क्लिनिक. So that's true. That bottom line is that you have a long term relationship and try to build that up. That's important. और आपने सही कहा कि biologics के लिए आप लोग ये देखें कि आप ये ना देखें कि दुनिया में क्या हो रहा है. आप एक तो ये एब्रेस्ट रहें लेकिन आप ये देखें कि आप अपने पेशेंट के लिए यहाँ पर क्या कर सकते हैं. What's best that you can do? And the only thing that you can do is that I learned from outside world. मगर जो dermatology है वो मेरी यही. Whatever dermatology that I know or I don't know, it's only from the Mayo Hospital training. That's it, full stop. बाकी सब जगह मैं गई हूँ, dermatology में ऊपर नहीं गई. लेकिन जो चीज मैंने लर्न किया ना वो ये देखा है कि जो हम में होनी चाहिए, मुसलमानों में होनी चाहिए. हमने वो ये बैक की, मैंने देखा कि यहाँ नहीं है लेकिन वहाँ है कि वो पेशेंट डॉक्टर्स का इतना भले वो इसलिए करते हैं कि उनको सू कर ले. Of course, मगर that's one of the factors. मगर they have this, उनकी ट्रेनिंग में ये पार्ट है कि आपने पेशेंट के साथ कैसे डील करना है. That makes a big difference. It's a humongous difference. And I'm sure that you guys, if you think about it, you can be, I think, 100 times better than what you are. Right? So they don't know a lot of things, which definitely you guys know. Because you look from page 2243 to 258 on the bedside when you have to decide, then you definitely know better, right? So that's what we had, right? What I'm saying is that there's no lack of knowledge. It's just try to build up a relationship, and and I'm sure I'm seeing such nice things here, so good participation. And best of luck for your future. And if you have anything, my email address is here. I'm more than helpful. I'm happy to help you anyway, or guide you anyway, or actually hear your comment. And maybe I will ask the comment. Sometimes I need some help from you guys as well. Age is just a number. It can be 16, but it's okay. It doesn't matter. But the best thing I like is over here is the Huma Reber. मेरा hospital ना Huma Jafar है, लेकिन सारी dermatology मुझे Huma Reber. Reber is my husband, and I'm sure he's here, जो कि लोगों की cricket team का बहुत बड़ा part है. जी, तो वो उधर तो बहुत हैं, तो चले गए. फिलहाल तो आ जाएंगे लेने के लिए. तो नहीं रही मैं उन्हें भी कहना. तो बहुत खुश होंगे इसको देख के. And I'm very thankful for that as well. Thank you, ma'am. Thank you. अब उसे बता दूँ कुछ और question. बोलने की कमी नहीं. Thank you so much.
Thank you so much, ma'am.
Thank you.
Thank you so much, ma'am. Thank you so much, ma'am, for such an insightful and detailed knowledge regarding the biologics of psoriasis. It has really made us wise regarding our knowledge on the biologics and in psoriasis. So before we conclude, I would like to say thanks to our worthy professors, Professor Tahir Jameel, Professor Shehbaz, Professor Lamis, and Professor Anila Asghar for joining us in this workshop. Really means a lot, madam. So before we wrap up, we cannot conclude this workshop without the quick remarks by our worthy guests. So we'll start from Madam Farhana. We'll pass the mic and speak a few sentences regarding this workshop. Thank you, madam. Dr. Nadia Liasfar, ma'am, please.
This is the first time I've learned from Dr. Kumar. Actually, I was house officer when we were visiting to President in the hospital way back in, I think, 1999. And way back in And I'm so glad to meet her again, and we had such a lovely time even back then. I remember her dedicated to special round, where one product is around it. And I was really thinking that I would like to go here to make some of our depression, and I don't know why, very much this is a manner to मैंने सोचा कि मैं ना आउट ऑफ खेल मैंने तो मैंने तो उसको बड़ा अच्छा देखो नहीं वन ऑफ द पीपल आई एम हियर राइट नाउ टू कोर्स इन सम के आज तक याद है बहुत क्लियरली आई वेंट टू हर ऑफिस और मैंने उसके सारा तो मेरे पास से आगे फोकस पर जरूर डालूंगी कि मैंने कहा लेफ्ट आ गया तो मेरे पास अपना काम है बाकी हर चीज भूल गया तो मतलब उसको तो मोटिवेटिंग तो मैडम
Sir, please, your remarks.
Marvelous thinking of the text around both were not right. Very right. You are on it. After we are especially how to open how to open. Especially before deciding to use biologics, this is a different template of being the session before us then is very the first use this direction to interaction with the patient. But the concept is it allows to have more success. Whenever you come to talk,
Thank you, sir. Thank you, sir. Madam, please.
Biologics in your heart, and using biologics in the Western world or in North America. So आपके लेक्चर से हमें वो जो डिफरेंसेस हैं और वो जो हमारी कमियां हैं वो काफी हद तक सीखी गई और इसमें डिफरेंस है देखो हम क्या किस तरह यूज कर रहे हैं और आप किस तरह यूज कर रहे हैं इसमें डिफरेंस है पर वो जो एक गैप है वो हमें काफी सही कर रही है बायोलॉजिक्स आप लोग ज्यादा कॉन्फिडेंट भी हो सकते हैं अगर कोई नया लाना है उसके बारे में I don't know, तो हमारे हाथ से नहीं है वो तो मतलब थोड़ा बैठ कर लागू बात कर ले कोई हाथ से
Thank you, madam. Respected Professor Shabazz, sir, please some few remarks.
Yeah.
तो एक फ्रेंड और एक दूसरे को प्यार मोहब्बत से देखते करें और पेशेंट और फुल
हमारे वहाँ भी I'm sure आप लोगों में भी होगा, you have a need in dermatology, so don't
Dr. Lami, few words.
आप बस बात कर सकते हैं ताकि आप आपस मतलब कैरेक्टर क्लियर रखो हम करता है
Madam, Dr. Lami's.
I've met you once before, but दुबई से आप मुझे मिली थी और आपसे जब मुझे मिली तो आपने मुझे कहा I'm from where are you from? I'm from Europe. मैंने कहा okay I'm from US. We very closely comrade. फिर है ना एक दुनिया में कहीं कहीं हम जाए तो I just want to say कि they all because you are telling the person that I think are तो हम अपने लिए एक लफज इस्तेमाल करते हैं फालूदिया आलिया फालूदिया दुनिया फालूदिया आलिया फालूदिया तो ये the greater हम खाता होते हैं आपके करते हैं we are all we are part of we are all part of the same plan and wherever the world is inshallah जहाँ हम मिलते हैं हम ये सोलो चेंज करेंगे very happy what I am because of this we are all because of thank you very much ma'am.
Thank you, ma'am. Respected Professor Tahir Jameel, sir, please speak a few words.
बात करें अपनी चैनल बात करते हैं
Thank you, sir. Sir, please, Professor Ijaz Hussain.
हम अपना नहीं देखते हैं पेशेंट जब ठीक करना हो तो प्रॉब्लम और उसके साथ एक हमारा जो देखते हैं जैसे मैं उससे हमारे कभी लेटे का तीनों बहन के जो साइड इफेक्ट मैंने देखे मैं ये हम हमारे क्षेत्र में थोड़ा
Eprimilar.
sustainability. अगर आप ये बहुत तो आपको होता है लेकिन कमी भी होती है एकदम खर्च करने के लिए क्यों हो गया लेकिन लगातार लेकिन कंट्रोलेबल है उसके लिए तो बिल्कुल खर्च करके कैसे आप
मेरे घर में आप नहीं
मैडम घर को इस्तेमाल कर रहा है जब किसी का मुंह बंद कराना तो
मुझे ऐसी लग रहा है कि प्रोफेसर बात है
और ये एक मैडम के ऑनर और ये फेलो डिफेक्टर होने की वजह से तो एक दूसरे के साथ तो ये कहते हैं कि आप महिला कीजिएगा क्यों ना तो एक वक्त बिटवीन हो रहे होते हैं ना एक जगह तो उनकी आपस में कितनी दोस्ती होती है वो आप महिला कीजिएगा कि जैसे सारे साहब को जब मर्जी जहाँ पकड़ लेता है सारे साहब को विश्वास साहब को
सारे साहब
सॉरी सर
जी जी Thank you, sir. Thank you so much, sir. And thank you to all the respected seniors for their valuable remarks. Let's conclude this presentation and the workshop with the shield distribution. I would request Professor Ijaz Hussain and Chairman of PADCON, Professor Lamis and Professor Nadia to come on stage for the shield distribution. Sir, idhar. Sir ki shield hai. Sir is the chief guest. Okay. Sir, please. Please, sir, join us on stage. सर आपकी तो शील्ड सेपरेट थी तो हमने कहा सर को दोबारा से एंड में बुलाएंगे सर शील्ड डिस्ट्रीब्यूशन है सर आई विल अनाउंस नहीं So ladies and gentlemen, please give a big hand to our speaker of today, Dr. Umar Ehbar. हाँ मैडम जी
आप पेट्रन है
ये वाली अभी आप मैम रहे आप लोग उधर ही रहे ना चीफ गेस्ट दे दो मैडम को ही सर
ये जो ऑडिटोरियम बना इसकी सीटें ये कुर्सियां क्या होंगी स्टेज कैसा रहेगा सर तारिक साहब और सर साहिब जमील साहब इनका बहुत रोल है इनके लिए एक बार तालियां
नाउ आई वुड रिक्वेस्ट आप ही देंगे चीफ गेस्ट नाउ द शील्ड्स फॉर आवर चीफ गेस्ट सर ओके नाउ आई वुड हाँ Thank you, madam. Now I would request Professor Ijaz to distribute the shield amongst the chief guests. Our first chief guest for today is Sir Tariq Rashid. हाँ हाँ
और अक्सर थोड़ा सा लेट हो जाती थी, सब आपको डांटते थे। अच्छा, एक दिन ना बड़ा सा आप डांटा ना, आज लगा क्या किया?
मैडम आप भी आ जाए मैडम प्लीज।
वैसे मोहम्मद को मैंने ला के रखा ना, चलो नाम मैं उनके पास बैठ, मैं काम करूँ।
Thank you, sir. Our second chief guest, Professor Tahir Jamil. Please, sir, receive your shield.
आवाज़ें तो नहीं जा रही। जैसे लाइव जा रहा था।
Thank you, sir. Third chief guest, none other than Professor Shehbaz Aman. Please, sir.
मैडम आप मैडम पाकिस्तानी
Thank you, sir. Last but not the least, our fourth chief guest, Professor Dr. Farhana. Thank you, ma'am. Now the flowers for the beautiful ladies. First of all, I would like to request Professor Lamis to receive the bouquet from.
उन्होंने शरत ला दी थी नाटे को देव मैं कर सर आज ना ये मैं
Thank you, ma'am. Thank you, ma'am. Dr. Nadia Ali Asfar, madam. Dr. Nida. Thank you, madam. So let's conclude this shield presentation with the bouquet presentation to Dr. Anila by Professor Tariq Rashid.
एक आप में और मैडम में एक बात कॉमन है, वो बात बताओ।
Thank you, sir.
एक में मैडम दाखिल लगी, सर तुझे ना
Here. So we are concluding this workshop with the best wishes for the PADCON team and looking forward to a great event, inshallah. Join. Thank you, ma'am. Really insightful talk.
ये वाला बस मैं आप लोगों से सिर्फ ये कह रही हूँ tomorrow 8:30 AM everybody should be in Expo Center in the conference. Inaugural sir 8:30 AM सुबह 8:30 बजे. Inaugural at 5 PM. The chief guest is Dr. Amjad Saqib.
Thank you. Please join for the thank you very much.